Have you ever noticed someone who just seems to keep growing? Not just taller, but maybe just proportionately or with other unexpected features. It's definitely more than just being a big kid.
Hmm.
We're talking about a really fascinating and honestly incredibly complex area of human biology, overgrowth syndromes. Today we're going to do a deep dive into what overgrowth truly means in a medical sense. We'll explore the, well, surprising genetic blueprints that drive it and unpack how these conditions show up in ways that are often much more than meets the eye. Think of it like we're peeling back the layers of a fascinating biological puzzle, and we've got a fantastic stack of research to guide us.
Yeah, and what's truly striking here is how observations that seem simple, right, like a child's height or their head circumference,
Mhm.
how those can be the entry points into understanding incredibly nuanced genetic stuff, cellular processes. Our mission today is really to connect those dots for you, show you how medical professionals actually approach defining, diagnosing, and, ultimately managing these rare conditions. It's really a testament to combining careful observation with cutting-edge genetics.
So let's start right there with that fundamental question. When we talk about overgrowth medically, how much over are we really talking about? What's the specific measurement that signals something might be going on beyond just natural variation?
That's a great place to start. It's not just a subjective feeling of, oh, that kid's tall.
Yeah.
Medically, overgrowth is typically defined when a child's growth parameters, height, maybe head circumference, measure more than 2 standard deviations. We usually abbreviate that SD. So more than 2 SD above the average for their specific age group.
Okay, 2 standard deviations.
Right. And to put that in perspective, that represents roughly the 98th percentile of the population. So if you took 100 children, only about 2 would naturally fall into that category just by chance.
Got it. So it's a very specific statistical cutoff. That distinction must be crucial, right? Because it helps doctors tell the difference between a healthy child who's just naturally tall and one where there might be an underlying condition. You also mentioned head circumference. How does that fit in?
Exactly. That statistical measure helps focus things. And yes, besides height, an increased head circumference, we call that macrocephaly, is a really important flag. Like height, it's often defined as being more than 2 standard deviations above the mean.
Okay.
And if you see both increased height and a significantly large head circumference together, that immediately raises the suspicion for a syndromic overgrowth. It helps differentiate it from just, simple tall stature.
That makes complete sense. But I guess even a tall child with a large head doesn't automatically mean it's a syndrome, right? So if a child has both that global overgrowth, increased height, and head circumference, what else needs to be present for a doctor to really raise that red flag and, start digging deeper?
That's right. If both height and head size are increased, the suspicion really ramps up if there's also an intellectual developmental disability ID and or other congenital medical anomalies. We're talking about things like heart defects, maybe kidney anomalies. That combination, overgrowth plus ID or other anomalies, that's a strong signal for further genetic investigation. It really points you where to look next.
Okay, so we've defined what it looks like. Now, this is where it gets really fascinating for me, the molecular reasons underneath it all. Our sources point to 2 main families of genes that keep cropping up as key players in these syndromes. What are they, and how do they actually affect growth?
Yeah, it really comes down to cellular control mechanisms. The 2 main gene families are, first, epigenetic regulatory genes, and second, genes within the PI3K-MTR pathway.
Epigenetic and PI3K-MTR.
Got it. So think of it like this. Epigenetic regulators, they don't change the actual DNA code itself, but they control how that DNA gets read and expressed. It's sort of like the dimmer switch on a light. They control how much of a gene's instruction gets used.
Okay.
If you get mutations in these regulators, genes related to growth can be incorrectly turned up or expressed when they shouldn't be. The PI3K-MTR pathway, on the other hand, that's like a central highway for cell growth, proliferation, survival, metabolism. It's fundamental.
A superhighway. I like that. So what happens if that pathway gets, well, overactive, like stepping on the gas too hard?
Well, if the PI3K-MTR pathway gets activated, yeah, it directly results in increased growth. The cells just keep getting the go signal.
Makes sense.
But what's also really interesting is if you have inactivating mutations in the inhibitors of this pathway, think of those as the brakes.
Okay. So if the brakes fail.
Exactly. If the brakes, like the PTN gene, for example, aren't working properly, the pathway just stays on uncontrolled, and you still end up with that excessive growth.
Can you give us an example, a specific gene, one of those gas pedals you mentioned, where activating mutations lead to these disorders?
Absolutely. AKT1 is a key example that comes up a lot in the research, but there are others like AKT3, PIK3CA, TIK3R2. They're all important parts of this pathway. Activating mutations in these basically keep the pathway switched on constantly, just stimulating cell growth over and over.
Okay, that paints a clearer picture of the mechanism. Now, let's shift gears slightly. When a doctor is assessing a patient suspecting an overgrowth syndrome, they're looking beyond the child right there, right? They dig into the past. What specifically should they be asking about from the mother's pregnancy history?
Oh, absolutely. The history is critical. Gestational diabetes in the mother is particularly important to ask about. It can significantly affect the baby's size at birth, what we call macrosomia, and it's a known risk factor for certain syndromes like Beckwith-Wiedemann or BWS.
Okay, gestational diabetes. Anything else?
Yes, another big clue from the pregnancy can be polyhydramnios. That's an excess of amniotic fluid. Both of those things can suggest something was affecting fetal growth differently.
And moving from pregnancy to the birth itself. What details from the birth and the neonatal period are really crucial for picking up these conditions early?
You really need all the details there. Birth weight and length, obviously. Gestational age is key. Head circumference, often noted as OFC. Any complications during pregnancy or delivery. And crucially, neonatal hypoglycemia, low blood sugar right after birth.
Low blood sugar, okay.
Yeah, these details together provide vital clues for an early diagnosis. They're particularly relevant for conditions like BWS, where hypoglycemia can be a serious issue for the newborn.
Makes sense. Beyond the patient's own history, family history is always a huge piece of the genetic puzzle. Other than asking about obvious overgrowth in the family, what other family history aspect should a clinician really focus on?
Well, the presence of intellectual disability ID in the family should definitely be asked about specifically. Many of these overgrowth syndromes are associated with ID, so finding a pattern in the family can strongly suggest a hereditary component and help guide the diagnosis.
Right. And sticking with maternal conditions for just a second, for babies born to mothers with diabetes, we know there are increased risks. What specific congenital malformation risks are particularly higher for these babies?
Yeah, babies born to diabetic mothers, especially if the diabetes wasn't well controlled, face increased risks for specific things. We often see a higher rate of congenital heart defects and also neural tube defects, plus various skeletal anomalies too. This is thought to be due to the embryopathic effects of the maternal diabetes environment during early development.
Okay. So we've covered definitions, genetics, history. Now let's get into what a doctor actually sees during an exam.
Yeah.
If a patient has regional overgrowth, like one arm or leg is noticeably larger, what specific things should they look for on the skin?
The skin manifestations or cutaneous findings. They're incredibly important in these regional or segmental overgrowth syndromes, and they're not just cosmetic. They're often really important diagnostic clues.
Like what kind of things?
You might look for unusual pigmentation, maybe lipomas. Those are benign fatty lumps. Hemangiomas, which are vascular birthmarks, and specific types of moles called connective tissue nevi. These signs can really be the key puzzle pieces.
Could you use an example? Say in Proteus syndrome, is there a characteristic skin finding?
Yes, absolutely. In Proteus syndrome, a defining feature is often the presence of connective tissue nevi. They can look quite distinct, sort of thick and grooved, and they're frequently found on the soles of the feet. It's a key diagnostic sign.
Okay, soles of the feet. And what about PTN hamartoma syndrome? Any specific skin or mucous membrane signs there?
PTN also has its own set of characteristic skin markers. In males, for instance, penile freckling can be a specific finding.
Okay.
More generally, you might see things called tricholomomas. They're benign skin growth, often around the face. Acral keratosis, which is like rough skin on the hands and feet. Papillomatous lesions, bumpy growths on the skin, or mucous membranes. Plus, lipomas and hemangiomas are also frequently seen, so the skin gives you a lot of clues for PTN.
Wow, okay. Beyond the skin, what body region is absolutely critical to examine carefully for what are called dysmorphic features, those atypical physical characteristics?
The face. The face is a critical area for really careful examination. Many overgrowth syndromes have unique facial dysmorphic features associated with them. These are subtle or sometimes quite obvious differences in structures like the nose, the eyes, the forehead, the jawline. And they aren't random. They often form recognizable patterns that provide really key diagnostic clues specific to different syndromes.
All right, let's dive into some of these specific syndromes now, because this is where all these different clues, the growth pattern, the genetics, the physical features come together. Let's start with Beckwith-Wiedemann syndrome, BWS. You've mentioned it a couple of times. What's a common feature, especially involving the tongue, that's also seen in another syndrome?
Yeah, a very prominent feature in BWS is macroglossia. That just means a large tongue. And what's interesting is this specific feature, the large tongue, is also seen quite characteristically in Simpson-Galabi-Bamel syndrome, or SGB.
That's GV, okay.
And this isn't just cosmetic. A large tongue can cause real problems like feeding difficulties, sometimes even breathing issues, especially in infants.
Right. Besides the tongue, BWS often has some distinctive features around the ears, doesn't it?
Yes, the ears often give you clues in BWS. You typically look for characteristic anterior earlobe, creases, little lines on the front of the lobe, and also posterior helical pits, which are tiny indentations on the back rim of the ear.
Subtle, but specific.
Exactly, subtle, but they're recognizable markers when you know what to look for.
And what about abdominal wall defects? What might you see there in a child with BWS?
Yeah. Common abdominal wall issues in BWS include diastasis recti, that's a separation of the main abdominal muscles. Omphalocele is another, where some abdominal organs actually protrude through the base of the umbilical cord.
Oh, wow.
And umbilical hernias are also quite common. These are important to spot early.
You mentioned the genetics earlier, especially chromosome 11p15. What's a key genetic change seen there in BWS? Can you maybe simplify what's going on?
Sure. So one of the most common genetic causes involves that 11p15 region on chromosome 11. Normally, you get one copy of the genes in this region from your mom and one from your dad, right? They provide balanced instructions for growth. In BWS, one common reason is something called paternal uniparental dyspy UPD11.
Paternal UPD11.
Yeah, it basically means the child inherited both copies of this part of chromosome 11 from their father and none from their mother. This imbalance, this sort of double dose from dad, disrupts normal growth regulation in that region.
Okay, so an imbalance in the dose of genes. What about the other mechanism you mentioned? Methylation.
Right. The other common finding in maybe about 50% of BWS cases is a loss of methylation at a specific control region. It's called KVDMR1, or sometimes IC2, also on 11p15. Think of methylation like little chemical off switches stuck onto the DNA.
Okay.
When these off switches are lost in certain areas, genes that promote growth can get incorrectly turned on or stay on too long, leading to the overgrowth.
That's a really helpful analogy. So just how common is BWS? And how does it compare in frequency to, say, Soto syndrome?
BWS occurs in about 1 in 14,000 live births. And interestingly, that prevalence is actually quite similar to Soto syndrome, so they're both considered rare conditions, but among the different overgrowth syndromes, they are some of the more frequently identified ones.
And if someone has isolated hemihypertrophy, that's the overgrowth of just one side of the body. Is that linked to the same region?
Yes, isolated hemihypertrophy is also usually associated with changes in that same critical 11p15 chromosomal region. It really highlights how important that area is for controlling growth symmetry.
Okay, let's pivot to Soto syndrome then, since you just mentioned it. What's the gene mutation typically behind Sotos?
Soto syndrome is linked to mutations or sometimes deletions in a gene called NSD1. It's inherited in an autosomal dominant pattern, meaning just one copy of the altered gene is enough to cause the syndrome. And yeah, prevalence around 1 in 14,000, similar to BWS.
Now, when we think about the typical facial features of Sotos, what features might someone mistakenly think are Sotos, but actually aren't typical for it?
That's a good point, because there can be overlap. But a round face and frontal bossing, which is a very prominent bulging forehead, those are not typically Sotos features.
Okay, not round face, not frontal bossing.
Right. Those are actually more characteristic of another condition called Weaver syndrome. Sotos features tend to include dolichocephaly, a long, narrow head shape, down-slanting palpebral fissures, meaning the eye openings slant downwards, and often sparse hair at the front and temples.
Got it. And how does bone age usually look in kids with Sotos? Is it normal for their age or different?
Bone age in Sotos syndrome is generally advanced.
Advanced.
Yes. So if you take an X-ray of their hand and wrist, for example, their bones look more mature than you'd expect for their actual chronological age. It reflects that accelerated growth pattern.
So if the round face and frontal bossing aren't Sotos, they point towards Weaver syndrome. What genes are linked to Weaver?
Weaver syndrome is associated with mutations in two genes, EZH2 and E. And these, like some others we've talked about, are also epigenetic regulators. They control how other genes are expressed. For EZH2 specifically, most of the mutations are what we call missense mutations. That means a single change in the DNA code swaps out one amino acid for another in the protein, affecting its function.
And when are those characteristic Weaver facial features, the round face, frontal bossing, most easily recognized by doctors? Is there particular age?
Yes, the typical facial features, that round face, the prominent forehead, often wide set eyes, maybe a chin that looks a bit pasted on, and sometimes a horizontal crease across the forehead. They're usually most easily recognizable between about 1 and 3 years of age.
So a key diagnostic window there.
It often is, yeah.
What other finding might you see in a newborn with Weaver, besides maybe soft, doughy skin or a hoarse cry?
In the neonatal period, you quite frequently see camptodactyly. That's where one or more fingers are bent and can't straighten fully.
Exactly. Okay.
And an umbilical hernia is also commonly observed right from birth.
Okay, let's move on to Simpson-Galabi-Bamel syndrome, SGB. You mentioned it earlier with BWS because of the macroglossia. What's its inheritance pattern in the gene involved?
Right. SGB syndrome follows an X-linked recessive inheritance pattern. This means it's caused by mutations or deletions in the GPC3 gene, which stands for glypican-3, and that gene is located on the X chromosome.
X-linked recessive, so that means it mainly affects boys.
Predominantly, yes. Because males only have one X chromosome, a mutation in GPC3 on that X is usually enough to cause the syndrome. Females, having two X chromosomes, are typically carriers or might have much milder features.
And on a physical exam, what's a typical finding for SGB, maybe somewhere on the body that's quite distinctive?
A distinctive finding often seen in SGB is the presence of supernumerary nipples, extra nipples. It's a notable clue, though usually not medically significant itself.
Extra dimples, okay. What about hand anomalies? Were there specific things to look for in the hands with SGB?
Yes, several hand anomalies can pop up in SGB. These can include brachydactyly, meaning short fingers, syndactyly, which is webbing between the fingers, and sometimes polydactyly, having extra fingers, so a range of digit differences.
Wow, the specificity across these syndromes is just incredible. There are a couple of others. Our sources mentioned Malin syndrome and Tatten-Brown-Raman syndrome. How do they fit into this overgrowth picture? What genes are involved there?
Yeah, they add to the diversity. Malin syndrome is associated with heterozygous mutations, meaning one copy of the gene is affected in the NFAX gene. It also presents with that picture of global overgrowth, advanced bone age, developmental delay, and the facial features can sometimes overlap a bit with SOTOS, so diagnosis needs care.
NFAX for Melon.
Okay. And Tatten-Brown-Raman syndrome, or TBRS, that's linked to heterozygous mutations in the DNMT3A gene. Another epigenetic regulator.
Another epigenetic one.
Yep. Key features there include long stature, often increased weight, sometimes with rapid weight gain in late childhood. And they have characteristic facial features too, like thick horizontal eyebrows and prominent upper front teeth.
It really shows the spectrum, doesn't it? Finally, in this group, Perlman syndrome. What's its inheritance? And you mentioned a tumor risk earlier. What's the high incidence tumor type there? That sounded quite concerning.
Perlman syndrome is autosomal recessive, meaning a child needs to inherit two mutated copies of the relevant gene, one from each parent. And yes, the tumor risk is a major feature. There's a very high risk of specific kidney tumors, nephroblastomatosis, which are precursor lesions in about 75% of cases, and Wilms tumor, the actual kidney cancer, in about 25%.
Wow, 75% and 25%. That's high.
It is. And it also has distinct facial features, wide, flat nasal bridge, an upper lip that's sort of everted in a V shape, deep-set eyes, low-set ears. But that tumor risk really drives the need for close monitoring.
Okay. Now, earlier we touched on PIK3CA gene somatic mutations. Can you remind us what somatic means again, and then explain how conditions like MCP and CLOV syndromes, which are linked to these, cause a different type of overgrowth?
Right. So somatic mutation means the genetic change happened after conception in just one cell or a group of cells during development. It's not inherited from a parent and isn't present in every single cell of the body.
Got it. Not in every cell.
Exactly. And because it's not in every cell, it leads to what we call segmental or mosaic overgrowth, meaning only certain parts of the body or specific tissues are affected rather than the whole body growing uniformly large.
Okay, mosaic overgrowth, so MCP and CLOV.
Both MTP, that's megalencephaly capillary malformation, and CLVV syndrome are associated with these somatic PIK3CA mutations. MCKP, for instance, can present with brain malformations like hemimegalencephaly, which is overgrowth of one whole side of the brain. It can also involve things like pachygyria or polymicrogyria. Basically, these are conditions where the folds on the surface of the brain don't develop normally, which can affect function.
Okay, brain involvement there. And CLOV.
CLOV syndrome is a bit different. The acronym stands for congenital lipomatous overgrowth, vascular malformations, and epidermal nevi. So you see excess fatty tissue growth, abnormal blood vessels, and specific skin lesions. The severity for both MCP and CLOBE can vary hugely depending on which tissues carry the mutation and how widespread that mosaicism is.
And Proteus syndrome, another mosaic condition you mentioned. What's the specific genetic cause there?
Proteus syndrome is caused by a very specific recurrent somatic activating mutation in a different gene, AKT1.
AKT1, okay.
It's usually the exact same change, p-glu 17 alleles. This mutation hits that PI3-KKT pathway we talked about,
Right.
turning it on too strongly in the affected cells, leading to really disorganized and disproportionate tissue growth. It can look quite dramatic.
This has been an incredible tour through so many specific conditions. Given this huge variety in the complex genetics, what are the general ways doctors diagnose these syndromes today? How do they figure out which one it might be?
Yeah, the diagnostic toolkit has really expanded. Modern approaches generally involve genomic testing. This could be a genomic array, which looks for bigger chromosome changes, or targeted gene panels that test many relevant genes at once, or even broader tests like whole exome sequencing, WES, or whole genome sequencing, WGS.
Like some are genome sequencing.
Right. These methods allow for a really thorough search for both large-scale chromosomal imbalances and subtle single-gene mutations, helping to pinpoint the precise genetic cause.
Now, if a patient with suspected overgrowth also has developmental delay, which seems common, is there any other specific genetic tests that should be considered, maybe one that isn't immediately obvious?
That's a really important point, especially when developmental delay or intellectual disability is present. The FRXA DNA test for Fragile X syndrome should often be considered.
Fragile X.
Yes, it's a common cause of inherited intellectual disability, and while it doesn't typically cause the same kind of overgrowth we've been discussing, it's crucial for the differential diagnosis. You need to rule it out.
Okay, good point. Can these syndromes be diagnosed prenatally before birth? Is that something done routinely?
Generally, prenatal diagnosis is only possible if a specific mutation or chromosomal anomaly has already been identified in the family.
Only if it's known beforehand.
Exactly. It's not used as a routine screening test for all pregnancies. It's targeted specifically when there's a known family history and thus a known risk.
Let's talk about management and long-term surveillance then. For BWS patients, you mentioned the Wilms tumor risk. What specific surveillance is recommended for that?
Yes, for BWS, especially for those with certain high-risk 11p15 genetic profiles, like that paternal UPD11 we discussed, or changes in H19 methylation, there's a well-established surveillance program. They typically undergo renal ultrasonography, that's a kidney ultrasound or USS, every 3 to 4 months.
Every 3-4 months. Until what age?
Until age 7. That's the peak period for Wilms tumor risk associated with BWS. The specific genetic subtype really dictates the level of risk and the intensity of surveillance. And interestingly, this same surveillance protocol, kidney ultrasounds every 3-4 months until age 7, is generally recommended for SGB and Perlman syndrome too, because they also carry that increased Wilms tumor risk.
That's very proactive. What about Soto syndrome? Are there specific heart or kidney issues to screen for there?
Yes, for SIRTAs, it's recommended to have an initial echocardiogram to check for potential heart anomalies. And a kidney ultrasound is also important to screen for any structural renal anomalies, which can sometimes occur.
Okay. And in SGB syndrome, you mentioned potential heart issues. What specifically should be checked?
In SGB, the concern is particularly around cardiac dysrhythmias, problems with the heart's rhythm. So investigations using EKGs are important to assess for those.
Okay, so we have this clear consensus for Wilms tumor surveillance in several syndromes. Are there similar agreed-upon recommendations for screening for other types of embryonal tumors like hepatoblastoma in these overgrowth conditions?
That's a key question. Unfortunately, the answer is mostly no, not yet. While the Wilms tumor surveillance is pretty well established based on strong data, consensus recommendations for screening for other embryonal tumors, like hepatoblastoma, a liver tumor, are still actively being developed. We need more research and long-term data to create those standardized protocols across the board.
Right. And one more on surveillance for PT and hematoma syndrome. We know adults have increased risks for cancers like thyroid, breast, endometrium. But what about kids who are found to have a germline PTN mutation? Do we know their quantitative risk for tumors developing during childhood?
That's another area where we still need more information. For children identified with germline PTN mutations, the exact quantitative risk of developing specific tumors during childhood hasn't been fully nailed down yet. We know they need careful monitoring, but defining precise risk percentages and optimal screening strategies for kids is still an ongoing area of research needing more long-term data.
Despite all the complexities and the remaining questions, it really sounds like there's exciting progress being made. Given that so many of these conditions have such a precise genetic basis, are there therapeutic strategies actually being developed or even used?
Absolutely, and this is definitely where things get very hopeful. There's significant research and development into therapeutic strategies, especially those that target that PI3KAKT-mTOR pathway we keep coming back to.
Targeting the pathway itself.
Exactly. Because so many different overgrowth syndromes stem from variants in genes within the specific pathway, researchers are actively developing and testing new drugs, pathway inhibitors, essentially, and other treatments designed to help control that excessive growth signal. It's a very active and promising area for potential future treatments.
What an absolutely incredible journey through these syndromes. They're just so fascinating and clearly complex. From understanding that precise statistical definition needing to be more than 2 standard deviations above the mean, to seeing the intricate jans between epigenetic genes and that PI3KMTOR pathway, it's obvious these aren't simple growing pains. And we've seen how these different combinations of features like macroglossia showing up in both BWS and SGB, or those very specific skin signs in Proteus and PTN, how they act like diagnostic puzzle pieces, painting unique clinical pictures.
Yeah, and if you step back and look at the bigger picture, what really stands out is the critical importance of a comprehensive, almost detective-like approach, isn't it? It's not just about what you immediately see, it's about weaving together knowledge of the underlying genetics, picking up on subtle cues and how a child develops, getting that detailed family history. And the pace of genomic medicine is just accelerating. We're uncovering more specific causes all the time, which crucially is paving the way for developing these more targeted therapies we just talked about. It shows how far we've come.
It really does. And this raises a final, maybe provocative thought for you, our listener. Knowing how much hidden complexity and information can be embedded in what seem like straightforward medical observations like height or head size, what other common, maybe everyday phenomena in the human body do you think might have equally complex and surprising biological explanations just waiting for their own deep dive?
Something to think about, definitely. And remember, in the vast world of human biology, there's always more to learn, always more intricate connections to uncover.